All right, good morning. Welcome to Palliative Care and Geriatrics Grand Rounds. My apologies for all of our technical difficulties and the early light morning strobe flashing this morning. I want to introduce our speaker this morning, Dr. Jake Strand. Dr. Strand is currently chair of the Enterprise Center for Palliative Medicine and assistant professor of medicine at the Mayo Clinic College of Medicine and Sciences. Dr. Strand received his MD from the Mayo Clinic College of Medicine in Rochester, Minnesota, and subsequently completed his residency training in internal medicine at Brigham and Women's Hospital. He remained in Boston for palliative medicine training with us here at the Harvard Palliative Medicine Fellowship Program. Dr. Strand serves on the steering committee of the Global Palliative Care Quality Alliance and is an associate editor of the British medical journal Supportive and Palliative Care. His clinical work is predominantly in the outpatient symptom management, pain, and quality of life clinic at Mayo Clinic, and his clinical research interests center around the integration of palliative medicine into the care of patients with cancer and advanced cardiac disease, management of complex cancer-related pain, and barriers to cancer pain management. He participates in several active national research protocols and lectures nationally and internationally on these topics. And because Dr. Strand is one of our former fellows, we gave him an extra added test so that none of his slides are up right now. We've got a lot of technical difficulties. He's gonna wing it and we're gonna make it work. So please join me in welcoming Dr. Strand.
All right, so we're going to tag team here while he's going to work the computer, and I'm going to at least get us started. Really, thank you very much, Dr. Dobbin, for having me back. It's an honor to be here. This is a place where I certainly feel I had my most formative training and full of colleagues and friends, and so I appreciate the chance to be with you this morning. I will quickly show my disclosure slide, but I have to read it to you, so I will just say that I have no relationships with any industry pertaining to this presentation, and I will have the added piece about copyrighted images are for citation educational purposes and not to be distributed in any fashion. The objectives of this talk, so I came up with this title, and I first gave this title to a group of colleagues, and they said, what's the punchline of the joke? Because the title is a heart surgeon, a cardiologist, and a palliative care doc walk into a bar. And I realized that I didn't have a punchline. So we'll try to work on one together and see if that works. But otherwise, my hope here is to talk about building palliative care into the care of patients with advanced circulatory failure. And my objective is at the end of this talk is that we will all be able to together discuss the rationale for intentional integration of patients with advanced circulatory failure with our palliative care teams, to describe the arguments for actually triggering palliative care involvement in patients with circulatory failure, and also to identify some future directions for palliative care collaborations in very specific populations. So I will just sort of, my other disclosure is really more one related to sort of my own personal interest in this area. And it's really from the fact that I'm not an expert in the care of patients with cardiovascular diseases and palliative care. My interests as a fellow here and subsequently have been predominantly in cancer populations. Those are the patients that I would love to take care of day in and day out. And my initial reaction when I was certainly in the last first couple of years of practice, when I was on the consult service or I was in the outpatient clinic and there would be a consult for a heart failure patient, I would say, all right, I mean, I can't use ketamine on this patient, I can't prescribe methadone, it's a very different consultative practice. And so it was less fun for me. It's not that I didn't appreciate the fact that these patients had significant palliative care needs, but it just wasn't my interest. But I started to develop it first, certainly from some patients, but also really specifically as I started to delve into more leadership positions from a strategic partnership perspective. And so that's what I want to do. I just want to spend some time today is really also talking about the strategic value of those collaborations within a complex healthcare system. So I think many of us, I don't need to go too much into the why, but I will just add a few things. That patients with heart failure are numerous. About 6 million patients in this country live with heart failure in this country. Almost 1 million new diagnoses each year. That patients with end-stage heart failure are hospitalized quite a bit, 4, 5, 6 times near the end of life. And that takes a significant toll from a utilization standpoint and certainly from the patient experience standpoint. When we look at Medicare data, about 80% of patients with heart failure are going to be hospitalized in the last 6 months of life, with that trajectory and tempo increasing as they get closer towards death. I think interestingly, when we think about hospice populations and with heart failure, that about less than 10% of patients with heart failure are ultimately enrolled in hospice. There are some studies suggesting higher numbers, maybe as high as 20-some%, as low as 4 or 5%, but it's low. And we look at patients discharged from the hospital to hospice. Again, those patients with heart failure diagnosis are often in the significant minority. And that's despite several potential benefits with a hospice model of care for patients with heart failure: decreased hospital days, increased likelihood of death at home, and from some more recent data from Dr. Gelfman and others looking at Medicare cohorts, potential survival benefit. Hospice stays are quite short, though, for patients with heart failure, often less than 7 days. For patients who are discharged from the hospital to hospice, almost a third of them have stays on hospice less than 72 hours, which I think most of us would agree is less than optimal. When we think about the symptom burden of patients with advanced heart failure, it's significant: fatigue, shortness of breath, decreased well-being, depression, and anxiety. And interestingly, when these patients come into the hospital for acute congestive episodes, sometimes we're able to fix those symptoms, but often those symptoms persist in areas and intensity much higher than when they came in, despite initial decongestion. When we think about the LVAD population, one of my colleagues talked to me about LVAD as being really a heart failure patient on steroids in terms of symptom burden, at least initially, and often in the complex postoperative course. And part of that, of course, is because patients who go to LVAD are patients with very advanced heart failure. And I think what we're seeing now is more and more centers beginning to build out their own LVAD program. So in the upper Midwest, where I practice now, 3 new sites opened in the past 2 years doing LVAD, and some studies suggesting that upwards of 250,000 patients in this country could qualify for LVAD implantation. And certainly falls into this really important category of very high risk, but potentially high reward for patients and their caregivers. And so because we are almost ready to show this picture, is so good. It's actually, I'll just preface it. I'm really going to talk it up. It's from a patient decision aid, but it does challenge some of our notions that LVAD is being really a group of patients that are suffering all the time. Because when we look at patients who survive out to a year, quality of life has improved for a good number of them. All right, we did it. Okay. All right. Thank you, everybody. Have a good day. All right. So right down there. Perfect. Okay, there's me. There's my disclosure. There are my objectives. I read through those. We got through the roadmap. We talked about diagnoses, hospice. There we go. All right. So, but I think the other piece is for patients, even out a year, one of the things that we see in terms of symptom burden are significant utilization and hospitalization. So rehospitalization for any cause, significant bleeding. About 10% of patients at a year will suffer from stroke, up to 20% by 2 years in some studies, device-related complications, and for many patients, ongoing heart failure despite LVAD implantation. So one of the things I want to do just for a couple of, maybe about 30, 45 seconds here is turn to your neighbor. We have some nice dyads and people who could reach down and hopefully not fall over. And just spend about 30, 45 seconds talking about 1 or 2 advantages to systematically engaging with these patients. And what I mean by systematically is it's not the distress consult, but really thinking through how we might more directly partner with our heart failure colleagues, either in the inpatient setting or the outpatient setting for those patients with circulatory failure. And I'll time us here a bit abbreviated given the technical difficulties. We're working. All right, so I will start to call us back to order here. That was quite a robust vibe in the room, so I don't mean to slow that down. I will just keep us on track. Anybody want to share a couple advantages that they see? Yeah. Yeah, so those are themes that we're going to come back to again and again throughout this discussion this morning, is that communication and consistency. And it seems obvious, right? In palliative care, that's what we do communication. But that has been one of certainly our pitfalls, is the lack of consistent communication, because unlike often our oncology colleagues, they're not down the hall. They're not patients we often do off-the-floor visits on. And so there is a difference. And that's, I think, those are some of the key themes. Anyone else want to share another thought? Remember, we're all good at silence in palliative care, so I can stand here for a while. All right, I'll save up for the next question. Okay, so I think the benefits, beyond the communication, there's also, I think importantly, I just want to touch briefly on the patient-specific benefits. And I think what we've seen is more and more really intriguing studies prompting further discussion about how much we can help for patients with advanced heart failure in a systematic fashion in some clinical trials looking at integrative palliative care with heart failure, reporting out in some settings improved self-reported quality of life, symptom burden, improved spiritual well-being, and in the more recent Palliative trial, some of the utilization data was just reported out. Rob Menz and colleagues from Dr. Rogers' trial talked about this trend towards non-cardiovascular related hospitalizations. It didn't meet statistical significance, but certainly intriguing to think about as we design systems, and then importantly, ask for support from practice leadership to implement those systems about what we might benefit from the patient side and from the system side. So one more thing, we'll take that excitement and talk about barriers. So certainly communication. I can imagine that lack of communication certainly is a barrier, but what other barriers do people identify? And again, we'll spend about 45 seconds talking together about barriers and then come back. All right, can I ask for another couple of volunteers to share some barriers? Yeah. Wonderful. Yeah. So thank you for bringing that piece up, because certainly the outpatient, I mean, I think that's another area. I think it's one thing to think about in the hospital, but then what happens at home, what happens about rehospitalizations, what symptoms are the purview of a home-based palliative care or a hospice team, what symptoms do we have to reach out to the cardiologist for? That negotiation has been a struggle, certainly on our end. Any other? All right. So I think the other barriers that I'll just touch on briefly, really I don't think we build walls purposely between our groups, but I think there is still and persists, and again, taking from our experience at Mayo and a variety of different practice environments, which I'll touch on a bit, that there still is this idea that palliative care and hospice are linked. I still see, despite some of our greatest champions about palliative care integration, this idea that, well, we're transitioning into a palliative care mode, which really, I think they mean hospice. They don't mean to mean hospice, but it's like the Fluency Direct system auto-corrects it into palliative care somewhere in our system, in our Epic system. And I think there's also a growing sense that, gosh, we do palliative care, and they're absolutely right. our cardiology colleagues and primary care colleagues who are taking care of patients with advanced heart failure are doing palliative care. And so what does that mean from a subspecialty perspective? What does that mean for greater integration within a clinical setting? And then I think this piece I find still really tricky, and we'll start to touch on this a bit today, is this idea of specialty access. So where do we have those teams and who needs to be a part of it? And then the clear referral points. When do these patients get referred? Where in that waving trajectory of a patient with advanced heart failure or with pulmonary hypertension do we engage a palliative care team, if at all? So, and I think the slippery slope piece is the other one that's tricky. And so I was telling my son about this several years ago, about advanced heart failure and how the slippery slope, and this was his face. No, he's just a ham, and I asked him to do a funny face, and that's what he did. But it does make our team, I can tell you, it makes our team very worried that when we were having these conversations early on about increasing our penetration with heart failure, well, what about all these other patients that we're going to now get called on? And can we say no if we're saying yes to this group over here? So I'm going to just skip this piece, and we'll come back to it at the end just in the interest of time, and just want to share a bit about where we started, and then talk about some of those intentional integration points and some of the lessons learned from a strategic perspective. So at Mayo Clinic, it's an interesting collection of systems that are now integrated into one Mayo Clinic enterprise. We have the Rochester mothership, and then practice points as tertiary referral centers in Arizona and Florida. And in the last decade, a really growing group of hospitals, both community access hospitals, hub hospitals in the upper Midwest, and an incorporation of that practice as a one singular practice entity. And so palliative medicine started to follow that area. And after sort of colleagues who preceded me laid a tremendous groundwork to bring palliative care out of general internal medicine, oncology, family medicine, as kind of niche practices into an independent multi-specialty practice, which is really it's a department, sort of, recognizing the fact that many of us come from different practice areas, from whether it be neurology, PM&R, internal medicine. And I remember when I first started getting involved from a leadership perspective, I was talking with Dr. Jackson, mentor, who's been very gracious enough to lend her advice, and she was like, "What the hell do they want you to do?" And I had a hard time answering that question, and then it was answered for me, because the email announcing to our entire practice the formation of this palliative medicine center was that we had to ensure the success of the strategic growth initiatives of the institution, which seemed like a very broad mandate. That seemed a lot to do. And so we tried to drill down a bit more into what that actually was going to mean for us on the ground. And a lot of it was, we want you to help build out service line integration of palliative care into some of our priorities. And they centered around neuroscience, transplant, oncology, and then cardiovascular care. And at first, we were bombarded with, well, here's all the things that you could potentially do, right? We could talk about payer projects and hospice utilization, goals of care alignment, and mortality reporting, and that felt very overwhelming. So again, pushing a bit more, particularly thinking about cardiology, we were asked to think through, so when we look at the average monthly costs, they're often centered, again, in that last time period of life for patients with advanced heart failure. So from a strategic standpoint, can you do anything that may help better align the care for patients that also impacts our utilization? So that was one request. I think there are lots of other good reasons, and I think the other good reasons center around the work that has been done by so many of you in the oncology space from an early integration standpoint about those standard expectations, the standard communication. For us, it actually became very important because we had people who were on service one week to another giving very different types of consults to patients with advanced heart failure from the VAD group, and it was very frustrating for them, and also frustrating for our team to think about picking that up over and over again. Our social workers and nurses and advanced practice clinicians in particular, who are on service more frequently, found that variation and lack of expectations really difficult to work with. The other piece is that when we thought about the reasons to make routine our palliative care involvement, is that it allowed us to better advocate for resources. I was asked kind of point blank by the head of the one committee that allocates resources based on practice priorities to say, so what do I get for this incremental increase for a physician, for a nurse practitioner, for a social worker? And so that was really critical to have that answer at the tip of our fingers, but also across palliative care, that if somebody was going to have a palliative care consult with advanced heart failure or a VAD in Florida or Rochester or in Mankato, that was going to look similarly. The other thing that made this helpful, and I will say that we benefited from the fact that there were clear champions within the cardiovascular space who were willing to help us. And our goal, again, was to build this integration along multiple areas. We actually started predominantly with research space. So we started with a group who started working on some surveys and looking at the Rochester Epidemiology Project, which tracks a number of community participants in the Southeast Minnesota region, and how that related to heart failure and palliative care access. There was ongoing organic growth within our heart failure and particularly in the CCU. And interestingly, a nut we had, I still have a hard time cracking, but it got much easier when the cardiovascular surgery practice hired a surgeon who came from another institution where ethics and palliative care and nursing and the anesthesiologist all met every morning to talk about transplant, bad patients, and high-risk CV surgery as part of their routine practice. And he kind of wondered, well, why don't we do that here? And so that was very helpful in even thinking through better VAD integration as a place to start. And so many people agree that one of the things they wanted to do was move palliative care upstream a bit so that we weren't consulted at the very end of life or as a distress, but try to get some movement backwards in that hospital course, not even touching the outpatient practice to begin with. Some of the barriers that people mentioned and also some of the benefits, again, centered around communication and expectations. And again, that was critical for us. And we really wanted to move away from this concept of, oh my goodness, this person's dying, we don't have a plan, can you come help the family? And I remember running to the CCU at one point for a patient who they had really not wanted palliative care involved because we were moving forward. That changed very quickly. And by the time we got there, the patient had died. And it was a very unsatisfying component for all involved. And so we often talked about cases like that in building out some of our practice changes. We also did some surveying of our heart failure clinicians, of our cardiologists, and of our palliative care team. And so this is from one of our palliative care clinicians who said, doctor, this is my general response, Dr. X is on service that week. Crap, I know that we're going to get killed because they're going to send every patient to palliative care. And the next week, no one's going to do that. And so one of the things we were able to do is connect. So who was Dr. Crap? And found out that person was like, yeah, no, I totally get that. I send all my patients to palliative care because I know my partner is going to consult you next week. And so there was a kind of a rhythm there that was something we wanted to address. We also wanted to move away from this idea that, well, we're going to do all of their goals of care planning. Like, it's palliative care's job to do all the goals of care planning. Now, I'm exaggerating a bit, but that's how it felt to our team, and it was something that we needed to address before we got into something more routine. I think the problem with that idea, though, is that the cardiologists, both the general cardiologists who were seeing these patients in the community, the heart failure team, were asking us very specifically, saying, look, we talk about this a lot, but there's a lot of variation and a lot of discomfort around these conversations. And this is a survey of both community cardiologists, tertiary care heart failure clinicians, and primary care clinicians in the upper Midwest, and their confidence in engaging certain conversations. And what just to point out here is that this idea about even talking about prognosis or end-of-life discussions, the high levels of confidence and the very high level of confidence, I think people felt much more confident talking about end-of-life when it was really end-of-life. But talking about prognosis, talking about hospice, and even providing, we didn't really get above 50% in many of these cohorts in terms of self-perceived skill. And it was viewed as one of the most important things that palliative care could potentially help with. And this is another study that looked at discordance amongst what patients would actually say when asked those questions and what was being recorded on a hospitalization. And so what I just would point out here is that there were many patients who had reported that they wished to be protected from CPR intubation, but were being listed as full code. Patients, and some of whom who were actually being listed as do not resuscitate or temp resuscitation, who wanted to go through resuscitation preferences. And so it at least pointed us in the direction that, although not perfect, this data not perfect, it was a place to look at in terms of better concordance. So we came about an idea of, so what is this going to mean for us? And I think what we had done before is that there was one champion who, that was the heart failure person. They were going to see all those patients, and very soon realized that I alone can fix it was not a mantra we wanted to proceed forward with. But we wanted to move back towards this concept of that we were going to be stronger together as a team and stronger together between heart failure and palliative care team, or the VAD team and the palliative care team. But that came with some very clear expectations. So we talked a lot within our group, both in Rochester and in Arizona, where they had the most robust intervention previously with their heart failure cardiologist and VAD team. And so we talked about the idea that if we were going to do this, if we were going to get engaged, that the triggers needed to come from the people who it was going to affect most. And frankly, that was going to be the team, the heart failure teams and the VAD teams, because even though, yes, it would affect our palliative care groups, it was something that we were bringing to them. And so they were still the primary management team for that patient. And so if we were going to do some triggers, because actually that was their request, that we just make this routine, we wanted to make sure that we were triggering the right patients at the right time and then providing a service that was actually helpful to them. So we heard multiple times, look, I don't want to go into a room and be asked why you're here. That was just something that from a team perspective, we didn't think was going to be a sustainable practice. I think the other piece is that we needed to smooth out the consult curve to be able to plan better. So having a team that would have to see, 10 new consult one week and 0 the next was very difficult to plan and allocate resources. Similarly, if we were going to do any sort of triggering, we had to figure out, well, who's responsible for building that implementation out? What resources do we use? Is it going to be through the electronic medical record? We ultimately used a sort of bridge strategy, and I'll talk about that in a minute. And then finally, one of the things that we talked about is there had to be education and engagement around building out primary palliative care skills in a more robust fashion within the heart failure and VAD practices. The expectations back to us, and this is just looking at Dr. Jackson's slides that I still enjoy from many years ago, and many of you who have been clearly leading that work, that we needed to have some core team being able to do some core functions. And that was going to be obviously the physical symptom burden, the probing of prognostic awareness, and talking through that, the adaptive coping components we wanted to be more intentional about, and then the collaboration and advanced care planning. So again, I just saw Dr. Temmel sneak out the room. I wanted to credit her with this, looking at this idea of within oncology, population-based palliative care interventions, and then applying that concept within our own practice, which is what we tried to look at. So we looked at patients with very high mortality and a waxing waning course, like patients with advanced heart failure, and built out the process for triggering inpatient palliative care consultations when they hit the door. Similarly, for patients in the coronary care unit, we saw a lot of organic growth, but again, it was variable. We weren't clear exactly which patients we should be seeing. So we talked about a pseudo-embedded model with some triggering function that would allow us to discuss those patients together. And then similarly with our VAD population, that we wanted to be able to be involved early and have some process throughout the course of a patient with a left ventricular assist device that would allow for better care and communication. I think the trigger route is challenging, and so a lot of triggers out there that in the literature are, I think, a little bit tricky because they rely on some objective but some subjective interpretations. Again, these all make sense to me intuitively when we think about symptoms, but the question is, well, where do those symptoms, what if they get symptoms in the outpatient setting? What's that trigger look like? Do they have to be in the inpatient setting? For us, it became challenging with too much still provider variation and potentially way too many patients. So we settled actually on looking at a scoring system. This is called the Get With the Guidelines score for advanced heart failure. And it really uses some very simple data that you can pull from the electronic medical record and build into a singular numeric score. And so what we did was really pick the score, which was for us greater than 50, that corresponded to a 6-month mortality of almost 50%. And there are lots of reasons why we went down this path, and we can talk about it afterwards, but it offered us a way to slim down the population of patients with advanced heart failure. Not saying that we wouldn't see other patients, but it gave us a window into what is this high risk of death, potentially highly symptomatic group of patients that we can target. This is also a group of patients that often is in contact with the healthcare system through readmissions. These scores, there's a variety of different scores out there. They're not beautiful for individual patient predictive value, but they are helpful in looking at trends, meaning the more comorbidities you start to develop, the more likely you are in the future to have readmissions. And they're also, frankly, there's some association and predictive value around inpatient mortality. So 10%, getting closer to 10% inpatient mortality with a score of greater than 50 is not insignificant when we have a volume of about 1,000 heart failure admissions per year in Rochester alone. So we also found that this is a group that had lots of comorbidities and was, again, highly symptomatic that we thought we might be able to have some impact on. And so with that, we began about a little less than a year ago a practice improvement project to identify these patients and trigger them to a palliative care team. And this was also how we were able to justify increased resource devotion to a specific palliative care cardiovascular team within the hospital setting. We knew we had lots of patient volume, but we didn't know how to allocate it. And we actually talked about just building out a cardiovascular palliative care team. And this was one of the ways that we were able to justify that incremental growth. And so we triggered those patients in some of our initial data. So I just pulled this recently. We have about 92 patients that have been triggered. We limited it geographically because we were curious about some of the local follow-up. And again, just some observations, not hard data at this point, but about 40% of patients from the team looking at chart reviews had some sort of symptomatic intervention. Interestingly, about 20% of those patients that we triggered enrolled in hospice, about 22 days prior to death on average. And interestingly, about 60% of the patients who died actually died on hospice, which was, again, looking at previous cohorts and improvement from a practice perspective. And there were lots of other things that we haven't done all the analysis on yet, looking at advanced directives or advanced care planning notes and other interventions around family support and family referrals. So in the CCU population, we just started doing this now, which is, again, taking that similar scoring system, which Jake Genzer, who's a cardiovascular critical care doc at Mayo, has looked at in about 10,000 patient encounters, or 10,000 patients admitted to the CCU. And again, these scoring systems tend to correlate with not just in-hospital mortality, but longitudinal mortality out to 6 months to a year. And what we started to do here is take these patients and incorporate it as part of our sit-down round. So when we built out this new team, we figured Tuesdays and Thursdays from 8 to 8:15, we were going to sit down with the CCU and run the list and do it in very quick fashion, talk about patients we were already seeing, patients they wanted to consult. And we started to incorporate this trigger as a way of saying, should we be involved in this patient? So less formal and more conversational, but it was helpful because we centered on some key populations: patients with advanced heart failure, with out-of-hospital cardiac arrest and family coping needs. And then interestingly, we have a growing group of patients with cancer and now cardiac complications. So switching gears a little bit into VAD, I think there are clear expectations that palliative care has to be part of the VAD process. What that looks like is very different from place to place, and we knew that we wanted to do that more consistently. I think our team and the VAD coordinators and the VAD surgeons really felt that patients could benefit because at some point they may start to decline a more aggressive path and focus more on comfort-directed strategies of care, and that they had symptoms that they wanted our help with. Predominantly delirium and nausea were two of the biggest triggers that they were curious for our involvement on. And I think this is Dr. Kirkpatrick's survey looking at a variety of different cardiologists and what sort of protocols are in existence. And this was reflective in our practice. So again, 3 different sites doing VADs. And what we found is that in a lot of places, everybody knew that palliative care had to be involved, but like the respondents, that a good many didn't have a formal process for bringing palliative care into the equation. It was sort of, again, more distress consults or awareness as opposed to specific implementation. And so this is work that several of our colleagues down at the Arizona practice have been working on for several years now, and it's something that we've now begun to incorporate in our Rochester practice. And so I'll just share pieces of it with you this morning. The idea that within a patient and caregiver experience, there is this timeline that they're going to walk through. And this is actually shared with patients in a variety of different discussion points. And it makes clear that part of the team is not just the surgeon, the LVAD coordinator, the heart failure cardiologist, the social worker, but it's also the palliative care, palliative medicine team. And that their job was to be involved in preparedness planning in the beginning, to talk about symptom management potentially in the recovery phase, although in general our practice has been to back off post-implant for a period of time for that acute aggressive care model that takes place. And then to re-engage when patients get out of the hospital and come back for their follow-up visits, assuming that they're able to do so, with in some places, Arizona's working on this monthly LVAD appointments that are also at the same time as palliative care at the same time as the LVAD appointments. This transitional phase is really when the cardiologists and the coordinators are seeing a significant functional decline or symptomatic decline, persistent heart failure admissions, for example, and really a pre-transition phase into the end-of-life care phase. And for us, it fit nicely into the interest of many in our team and from some of the heart failure surgeons to think about, or the heart surgeons to think about perioperative goals of care and what that means. How can we ask about trade-offs? How can we ask about symptoms that are affecting quality of life both now and after implantation? And then what are those preferences that do help inform patients and their caregivers and their decisions? So this is one example of now what we are incorporating into our medical record. And so I used myself as the patient, so I'm hopefully not breaking HIPAA on myself, about an advanced care planning note that we put in our pre-LVAD preparedness planning phase, talking about, again, the informed decision or the alternative decision makers, and then looking at some symptom screens. Do patients understand about their heart failure? What are they hoping to achieve with LVAD implantation? And we try to drill down on some functional goals as well. Our surgeons actually asked us really to look at the spiritual and cultural practices that are informative for patients in getting their care, based on some cases that they had, I think, a lot of distress about not knowing that ahead of time. And then the hopes, worries, and trade-off function, as well as, again, our process is making sure that this is not only documented in the electronic medical record, but sent directly to the surgeon and the coordinator, so we have very clear feedback loop on communication. So the way this looks, and the process that we're going to be rolling out more directly now, both in Rochester now and in Florida, is that, again, this 3-month return, 6-month return, yearly return, and then into a 6-month tempo in the outpatient setting. When patients transition to more a higher contact form, that we're going to deepen that engagement and look at some potential triggers for re-engagement in the inpatient setting next. Interestingly, again, in our Arizona practice, looking at it from a quality perspective, they were able to show some slight gains in preparedness planning, advanced directives, and in contact. But you can see, only about 60% of patients made it back to their palliative care visit, and then only about 50% of those got back to their second visit. So there still is a piece about follow-up and expectation and practice implementation that's impacting our ability to do this. I think some of the lessons we learned from this initial phase of our integration with the LVAD group was that we had to be engaged in again, formal session. So we have a weekly watch list with the LVAD coordinators, the surgeons, the heart failure cardiologists, pharmacists, social work, nursing, to review all of the patients who are potential implants, who are post-implant, and in the hospital, and those who are in the community, as to their functional status and healthcare utilization. And I think what we needed to emphasize is that we were not here to cancel anyone's case. We actually, when we had concerns about a potential difference of expectation and what the team was telling us, we had that communication directly as here's what we're hearing from the patient. We think this needs further follow-up. It's a bit more hands-off than I know some groups have been doing, but I think for us that was the practice piece that worked in both the Arizona and Rochester practices. What I will tell you is that the communication piece, particularly looking at kind of the curve 3 and 4, where patients are having really this terminal decline phase, that became tricky because we heard from patients and their caregivers, look, they've been through this so many times, we're not sure if we want to go back to the ICU, we're not sure if we want to go back and have another intubation, I'm not sure if this is going to get much worse, we don't want to go through more shocks. And that was really hard, I think, for our surgical colleagues to know what we were getting into. Were we convincing them that they needed to not go through maybe these temporarily aggressive procedures to get back to more improved functional status? And so that becomes still for us a very difficult nut to crack. One thing that we did, this is from Dr. Schaefer's nice letter now a number of years ago, looking at a process for deactivation of an LVAD. And the piece that I just want to point out here that I think was key for us to highlight, and it's on there, but it was being missed, which is that the surgeon who implanted the LVAD needed to be aware that this was happening. And we had at least 9 or 10 cases where the surgeon had no idea that the patient was going to be proceeding into a phase of deactivation of their LVAD at the end of life. And that obviously was problematic for a person who felt a significant covenantal relationship with that patient and family to know what was going on and when it was going on. And so it became, again, these small things from a communication standpoint had really important ramifications. One last piece on the CV surgery that I'll touch on is that there's some interesting movement on looking at these very high-risk patients undergoing CV surgery that may offer us an opportunity. And so this is something we're exploring currently, which is looking at patients who might be in an acceptable risk versus high risk. And the reason why I point this out is that there has been this suggestion in the surgical literature that patients at very high risk, high mortality, intraoperative mortality, might be better off doing this with VAD support. And if that's going to happen, then does palliative care need to come along? And so that is where we find ourselves now. But the problem is that we have a difficulty, again, in branching out a bit further because of that, I think just lack of historical relationship between the surgeons and the palliative care team. And so I spent over the past about 18 months, 3 or 4 different times going before the Department of CV Surgery and just kind of taking it and like, here's what went wrong. And they were spot on in many cases about things that went wrong in our relationship historically. And here's some quotes that I just wanted to share because they were emblematic of bigger themes. So look, we see patients who get better. We just have to push forward. And you don't see that we might do this for 5 months and it looks like we're torturing somebody, but they come back into our office and say, thank you for saving my life. It's hard to argue with that because that has happened. And I have also seen some of those patients now, certainly not as many as our surgical colleagues have, but it's true. I think the other thing that was tricky is that many of the surgeons expressed this idea that they were under attack. They were under attack from the ethics team, or they were under attack from the nurses. And so we had, we talked about sort of our preparedness plan. They're like, wait, you can tell us, you can help us say that patients might want to continue on this current pathway of care. And we said, well, if we do those conversations well and we're able to document what patients are willing to go through, that is something that we can all feel better about the goal concordancy of care. And interestingly, as we deepen some of our engagement in the LVAD group, we did see, and this is purely observational, a dip in ethics consults. And that's because a lot of the ethics consults were coming from really, I think, barriers in communication as opposed to true ethical dilemmas. Now, I feel very conflicted about this because I don't think ethics consults are necessarily bad things that people need to be protected from. They seek to support our staff. And so I'm stuck in, is this a good carrot that I want to latch onto from a strategic perspective? But it is just interesting to see about some of the themes that our colleagues are concerned about. One of the things that I'll just end with from the CV surgery piece is that this is still, for us, heavily reliant on having a champion. And unfortunately, one of our surgeons is leaving who's been a big advocate of palliative care intervention. I don't know what's going to happen in the next 6 months, depending on who they're going to hire and what that's going to look like. And so I think we're still reliant on that individual relationship generation to make that process work more effectively. Some lessons learned about this process over the past year and a half in particular is that for us, in Rochester in particular, it felt like we had some capacity and we needed to dedicate specific resources. We'd also hired an attending physician who had come from a program with very deep engagement with heart failure and cardiac surgery and who was very interested in taking us on. And for us, it helped with internal consistency and interestingly with satisfaction for our staff. People felt it was a unique team to be a part of the cardiovascular care group. Several of our nurse practitioners actually came from the heart failure and CV surgery practices, and so there were deep relationships there that we were able to draw upon. And again, those touch points, the heart failure touch point, the VAD touch point weekly, the CCU rounds together, were really and continue to be critical parts of our practice, along with frequent leadership follow-up. That's not to say that everything is hunky-dory, because I think there are still significant barriers. The infrastructure for triggering these consults can be very resource intensive, and it requires a lot of staff to be able to put this together. I think we're starting to see more requests now. Oh, hey, can we start to have a trigger for pulmonary hypertension, for ECMO? And I think the other piece is we have not had the same investment of being able to send, in the same way that you're doing here with the Continuum Project, that same investment of that concept of getting those primary palliative care basic communication skills built up on different sides. The other thing I'll talk about this, we thought you were on our side. One of the nurse managers on one of the floors that I think just has been really struggling with, I think, communications between teams and really appropriately distressed, a lot of turnover. They were really excited about our deepening engagement within the cardiovascular surgery practice. But at one point we had a meeting with some of the nursing leadership and said, look, we thought you were going to come in and help us. And instead you're defending the surgeons or the VAD team. That was not something that I anticipated. And again, I think it was tricky because one of the things that we thought we were doing is that we were helping to normalize some of the communications between teams and between what the patients were telling us in many cases. And that, I think, again, because many of these cases are very distressing, it brought up a new avenue that we have to address in terms of our team collaboration. And then again, similar to thinking about those triggers that people are asking for, more recently there was a question about, well, should palliative care see every elderly patient who's going to have an ICD generator change? So one thing that we're doing to try to make this less labor intensive is to build out a significant practice analytics component that can do this for us. And so this is a really ridiculous slide, but I just want to highlight one quick thing. So there's a significant concept about the sniffer software. that you can use natural language processing and laboratory data to identify patients at high risk of an RRT or other ICU activation. And so several critical care docs said, well, what about palliative care? Could we put this to use to identify patients for palliative care? Could we get data early on here and figure out, a scoring system and say, yeah, high risk should see palliative care, and then have a human filter that would generate consults potentially. It's an interesting idea. It's still in generation, and it offers the opportunity to take some of these scoring systems, like the Get With The Guidelines heart failure score that we've used, some of the natural language processing to look at key phrases that we're still working on, and then, again, do patients have advanced directives? Have they been seen in the outpatient setting by palliative care? And plug it into a very fancy computer. This is my dumbed down version because I honestly don't know all the things that they do, and then to validate it and see what the output is for generation of consults, really with the goal of seeing these patients earlier on in the course of their hospitalization. And that's the work that we're engaged in moving forward. The last thing that I'll share here, just in the interest of time, is the importance from our perspective in building out not just a hospital base, where we focus, but an entire approach around, again, how do we use the health plan itself, because Mayo has an internal health plan to, again, identify appropriate patients. How do we embed those skill sets and integration platforms within the home-based palliative care programs? How do we do embedded palliative care consults? And we're starting to do that in our employee and community practice. Again, we've talked a bit about the hospital piece, and then pieces in the future that we haven't done. How do we do better primary education? How do we get more directly engaged within the valve clinics or the heart failure clinics moving forward? There's other opportunities for engagement here. So my final thoughts, just again, I think many of us would agree that heart failure patients are patients who can benefit from specialty palliative care integration. The how really matters, and for us, it was really critical to identify those champions early on and to be able to learn from them. And I think that's the piece that has been really informative, is that, like the knowledge that many of us have gained by being in such close collaboration with our oncology colleagues in that early phase, we have to be as specialized in this area to be able to do this well and to move that forward. Just want to acknowledge the significant both practice implementation and research team on the cardiovascular side, and my colleague Kelly Christensen, who is one of our leaders in the outpatient practice, and then our cardiovascular palliative care team here. Also, we'll thank Dr. Kamdar, who has been a great collaborator in thinking through some of these practice parts moving forward. And with that, I will stop for questions.
Thank you so much, Dr. Strand, for such an enlightening talk and for jumping all of our technological barriers. I will open it up for questions.
Hey, thanks for the excellent talk. I had a question about this the score, GWTG score.
Yeah.
So it's only inpatient, or again, if somebody didn't do it and then somebody comes up on the first discharge follow-up visit and in the clinic, and we can kind of trigger that, or it's only the inpatient data plugged in?
Great question. So it was validated on admission data. So for a heart failure patient on admission, the reason why we ended up looking at it was just its potential impact in the outpatient setting after discharge, but that data really was validated on inpatient admissions. And so that is the limitation, is that it does leave us without a clear, some clear potential triggers using more objective data in the outpatient setting. That doesn't mean there aren't other triggers that people use, but that's at least.
And I think I missed it. How do you retrieve that data? Like, is there any, like, you go to online somewhere? Because the data must be there.
Yeah, so initially we actually used, the initial way that we used this was through there was a research study that was collecting those scores on every heart failure admission anyways, and so we kind of piggybacked off of their staff and used it to then feed that to the heart failure staff to trigger those consults. We're now moving into really using it, having it come directly from the electronic medical record to generate a list.
Great, thanks.
Yeah, thank you.
Other questions? I'll open it up for any questions from our remote sites. Silence. Maybe one final question here. We're a quiet group today. Thank you so much, Dr.
Thank you.
Strand.
Appreciate you having me.